When I was working at the Lakeshore General Hospital as a social worker in oncology and palliative care for many years, I was asked to go to the ICU to see a patient who was dying, and I went in to see him, and they wanted me to find a place for him because we didn't have palliative care then. And I walked in and I told him who I was, and he said, "What are you doing here?" And I said, "Well, I'm here to talk about the next steps and where you're really going." He said, "Well, the doctor said I only have 10 days to live." And I said, "Oh, well, I thought maybe we could place you somewhere because you can't stay here." And he says, "You brought the wrong form, lady. You go back and you get the heaven form, and then I'll fill it out for you." So he ended up living a year and a half, and I placed him, and he was very, very happy with us. As Manny said, the World Health Organization has clearly indicated that euthanasia and medically assisted suicide are not the responsibility of palliative care. And furthermore, Dame Cicely Sanders, who is the founder of the modern hospice care movement, said whatever our views on euthanasia, it surely cannot and should not be introduced as a logical part or extension of palliative care. At the West Island Palliative Care Residence, when Bill 52 was passed at the National Assembly at 3:36 last June, we sent a letter to the ministry and to pretty much everybody else we could think of at 3:37, opting out of Bill 52. We do not believe that palliative care has a place, or euthanasia has a place with palliative care, and it's not considered a continuation of palliative care in any way. So we see it as two different subjects. As palliative care is, as many said, comfort, dignity, compassion, and the quality of life of the person themselves. It's an individual quality of life. We actually are changing some of our paperwork, some of our consent forms, so that people know when they come into our residence that we do not participate in Bill 52. If they want to participate in that after they've been in our residence, we will gladly refer them outside, but we will not participate in the residence for the simple reason it is not part of palliative care. I'm going to turn it over to Rose, who's going to tell you a little bit more about our residents.
You're leaving me. It's not fair. I'm Rose, the nursing director of the West Island Palliative Care Residence, and I've been there since it opened. I worked with Manny up at the Royal Vics for a number of years, and he was one of the people that helped me learn to practice quite a bit, and we got kicked out of many rooms at the Royal Vic together. People just don't want to have that conversation. They're very, very afraid. We did make a good effort, and eventually people do open up and have that. Once they realize it's not such a scary thing, and we're pretty non-threatening, when we used to go in rooms. But when we went in, we'd say, "Hi, we'd like to, see what we can do to make your quality of life better." Maybe even we're from the supportive care team. Sometimes we use that term. Sometimes we use the word palliative care and watch their faces get very, very frightened. But our goal really was to try and do what the patient wanted. And sometimes it was to transfer to a palliative care unit. Sometimes people wanted to go home. I still use those same methods that we did many years ago with the Vic today at the residence, because sometimes people don't want to die in a hospice setting. We use the word hospice throughout North America. It's not used very much here in Quebec because the word in French doesn't translate very well. It's a hard word in French, actually. So when Balmain learned from Cicely Saunders over in the UK a little bit about palliative care, she's the founder of palliative care. He wanted to bring a word back that really meant it to cloak, actually the Latin word means to cloak people, to take care of, to cover people. So the word palliation is basically what we do, but we do it in a community setting. And we really try hard to have a lot of conversations with patients, hopefully their families as well, before they get admitted to the residence. We have nine beds in one part of the residence, and 2 blocks away we have 14 other beds, which makes us now the largest freestanding hospice in Canada. for the time being. It has been helpful for sure having 23 beds now. We're able to meet most demands. As Manny was saying as well, it is hard to prognosticate people. People are individuals and all kinds of crazy things happening. So you can have someone come in with lung cancer who came in from the hospital with pneumonia. The nurses go over, have end-of-life conversations. The person gets some antibiotics and suddenly they're not dying. So you get the conversation that happened like similar, I guess, to the person who went to Michelle Sarah's end this morning. And suddenly the person isn't dying anymore. And what do you do when you're in a palliative setting? We try and have those conversations early on in an admission with the patient and family and to see what other options are. It's really not a long-term care setting. There's not a lot of activities to do for patients. They're all private rooms. Conversations that we have with families are either in room or in private rooms just outside of the rooms that we have. We have an interdisciplinary team, so we don't call for consultation too much outside of the residence. Manny's lucky enough to have access to anesthesia and radiation oncologists, for instance. If someone needs radiation to control their pain, he has access to that. We don't. So we really do take care of patients more so at the end of life, but it is very difficult sometimes trying to figure out when someone is at the end of life. We try and focus on comfort and quality of life, whatever that is for that person. So one of the first questions the nurses will ask when they come into the residence is, what do you need from me? What can I do from you? How can I make your stay here as best as we can do that? And sometimes it means, would you let my dog visit? Sometimes it means, can my wife stay overnight with us? The answer to those questions is yes, of course. We've had patients who don't want to be wakened for breakfast. They're allowed to sleep through breakfast. It's very individualized care. It's very specific, and it does have the underpinnings or the foundations of dignity and trying to respect the autonomy of the person in the most dignified way possible. We're really trying to also be as least invasive as possible. So we're not putting in a lot of tubes. We're not putting in things into the body that would cause discomfort of the person. We're trying to manage pain and other symptoms. Maddie alluded to those: pain, nausea, vomiting, shortness of breath, confusion. Most of those are reversible. At least we can manage them. We're really fortunate to be here in Montreal, where it's actually the mecca of pain specialists. Most pains can be controlled in 2015. I promise you that. It's unfortunate as we go outside of the area, it gets a little tougher to find the specialists who can do that with. We also accept patients with all diseases. So again, it has to be, because we're limited in the number of beds that we have a 6-month or less prognosis. It is tricky to determine that in order to get a bed in the residence. We'll take patients with all diseases, so ALS, Alzheimer's, but it really does have to be clear that it's end of life. We have a couple of physicians, and the physicians who refer to us will make sure that there's proof on paper. There are x-ray results and CAT scan results, and there's metastases of lung cancer, so that we know that pretty much, and we're right probably about 90% of the time. There is about 10% of patients who do end up going either back home or to a nursing home, living with a daughter. Again, family is a huge part of our care. The family is involved actually from before admission, from permission to come in. You agree that your mother wants to come to West Island Palliative Care residence. We either get on the phone, and I also have 2 nurses that we send over to the neighboring hospital just to have chats with patients, since most of our patients happen to come from the Lakeshore, but we do take patients from anywhere in Montreal, any of the hospitals in the downtown core. Our care, of course, is not curative focused like it is in the hospital. It's really comfort and quality of life. And it's usually done for the end of life. So, as I said, it's really for patients who do not have a reversible disease, right? And it's not we're not able to cure this. We're patient and family focused. patient does, assuming the patient can speak. And we try and take care of our patients and our families after the death. We have a bereavement service that does phone follow-up, and we have bereavement groups after the death of a patient. We follow them up to 2 years after the death. So I find that's really, really helpful. And you know what? A lot of people were alluding to this morning too as they spoke. The way people die and that process, how enriching it is so important for family members to go through that, to have that experience. We believe it does make a difference in your bereavement, and we feel that focusing on the family and their grief afterwards and making sure that things are going well during the process is extremely important to our team. So we have a team of social workers, bereavement counselors, of course, physicians, nurses, volunteers, which work in every part of our building. There's about almost 300 volunteers who work with us. They help the nurses, for instance, provide some bedside care. They can work in the garden, they work in the kitchen with our chefs. Our meals are geared towards patients. They're all homemade things. But if a patient, for instance, wants to skip breakfast, like I said, and sleep till 11 o'clock, they're welcome to do that. I had a guy a couple of years ago who wanted to have cognac for breakfast every morning, and as he did for the 30 years before that. So I said, well, you can have your cognac as long as, number one, we know how much you're drinking, because we're also giving narcotics along with that, and as long as you provide the cognac, because I don't have access. I've also had people who wanted to have, a couple people wanted to smoke pot too. Now it's by law you have to go outside to do that. So as long as I don't see it, we are fully supportive of that as well. It helps to manage some symptoms. Because we are really symptomatologists. We manage symptoms, but the symptoms can be physical, they can be emotional, they can be psychological. And that's why we have the interdisciplinary team to be able to do that. I mean, no bones about it. I realize how very, very lucky we are in Montreal to have a pretty good palliative system. My concern is, in different pockets throughout the country in Canada, there is really good palliative care systems, and with residences, with tertiary care centers who do amazing work, and we have really good home care nurses, home care teams, physicians who go into homes who are able to manage people who want to stay in home. And it's pretty good on the island of Montreal. It's once you get outside of it that's a concern. So we struggle with, we're almost, we get, 1/3 of our funding is from the government. The other 2/3 we have to raise money for this kind of care. And that's where Teresa Dellar struggles every day, is having to raise $4 million now, $3 million a year, and it's getting tough because there's a lot of good causes out there, and for a government sometimes who doesn't prioritize end-of-life care, it's too bad. But in order to give this really, really good care, we have to raise money to be able to do that. Our team really, concerning Bill 52, life in a palliative care unit, we're really good fence sitters. We neither prolong life nor do we shorten it, except that this past December in the New England Journal of Medicine, they found that palliative care does actually prolong life. So they looked at people who didn't receive palliative care and those who got it, and the palliative care people actually lived longer. So we're really, really happy to hear that. It just gives us more validity, more credibility for what we do. Our physicians work hard to manage all those symptoms. We have lots of discussion with families about pain medicine and accepting pain medicine. We had a little discussion at lunch, a mini discussion about morphine. Morphine, you should know, is the gold standard really throughout the world. It's cheap and it's safe, and you need to know how to prescribe it in order to give it safely. I had a physician in an emergency room a couple of years ago call me up and said, I have a patient dying here in my emergency room. Do you have any beds? And I said, I don't right now. I said, can I help help you with something? And he said, well, what should I do? He's really short of breath. And I said, can you give a really little dose of morphine, maybe 2 milligrams, 2.5 milligrams, something small enough that it will make his shortness of breath maybe go away? He said, you're asking me to euthanize my patient. And I said, no, I'm not asking you to euthanize. I'm asking you to control his shortness of breath. So we need to educate a lot of our healthcare professionals as well as the general public about the safety that a lot of these medications do not cause death. The person is dying. And morphine, when given in the correct dosage, just like any other narcotic, just like Tylenol, just like any medication, you give it small enough, in small increments, and we're taught very early in school, please start slow and work your way up. And if you can control pain at the second level or whatever minimal level, then that's where you stop with your medication. If you need to go up higher and see if you can control pain, then you go up a little higher. And people in palliative care do not get addicted to any of the narcotics. So we're very strong on trying to control symptoms, physical, emotional, mental. That's what Manny referred to as holistic care, and that's what we do. Tees, do you have anything else you want to add in?
I just wanted to say that, there's been a lot of talk today and a lot of great information shared regarding some of the laws and Bill 52 and also the Supreme Court of Canada. Palliative care is a specialty. And people like Mandy, Rose, myself, and all our team, and 2 of our members here, Donna and Sandra, we work very, very hard to provide palliative care. It's a specialty. The Canadian Hospice Palliative Care Association in Ottawa recognizes that unless you have all these elements that Rose has described, including, I'm quoting Bridget's word, aftercare for the family, you're not doing palliative care. Palliative care encompasses everything that Rose and Manny have talked about. So it encompasses bereavement, family, we have art therapy, psychosocial. So you have to do it all in order to provide adequate and specialized palliative care. And that's really important when we're talking about all these bills. It's not just about the last moment of death. It's not just about the last second. It's about beforehand and after. So that's really, really important. And I think that with everything we've heard today, we know that sudden death and the ability to say goodbye can really, really change the grieving process. So we focus on that as well. And then, anything else you want to say?